Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by EuroTimes. I'm Sean Henahan. We're reporting from the World Society of Pediatric Ophthalmology and Strabismus Subspecialty Day held during the 32nd Congress of the ESCRS in London. Extra ocular muscle surgery to correct strabismus is among the most common of eye surgeries. Today it is often performed using adjustable procedures. We're fortunate to have with us today Dr. David Granet, a pioneer in the field. Welcome, David.
Thank you.
For starters, tell us, what are you doing today? How do you approach strabismus surgery?
Traditional strabismus surgery meant that you cut the muscles, moved them, and tied them down, and then when the patient woke up over the next few days to the next few weeks to months, you saw how they did. About 30 years ago, the idea of doing adjustable sutures started, and it's been developed since then, where instead of tying a permanent knot to hold the muscle, we can put a sort of a slip knot on the muscle, and in the first 24 hours, for most people now, you can slide that muscle just a little bit to fine-tune the surgery. But those first 24 hours are really difficult. You've just had anesthesia, you're uncomfortable. Leaving a suture hanging out of your eye is not the most pleasant thing for most patients. Patching their eye to cover it up so they don't pull on that stitch or get infected means that their eyes can't work together, when that's the goal, is to get the eyes to work together, so it defeats the purpose. We thought there ought to be a better way. And so, building on the work of many other doctors along the way and some of the research that we've done, we developed a technique that allowed us to adjust patients a week later. So somewhere between 5 and 7 days, we can adjust a patient and give them the chance to get over the anesthesia and give their brain a chance to start trying to use the eyes together, see where they'll land before we begin to adjust.
Now, have you found that that has improved your success rates? How are the outcomes?
The outcomes are actually terrific. Only 1 out of 10 people ever need to be adjusted, and the other 9, their sutures are covered, the conjunctiva is closed. We shake their hand, say, "Congratulations, Mr. Jones, you can go home," and no procedure whatsoever needs to be done. In the other way, the suture's hanging out of your eye, you've got to do something with it. So every patient undergoes some procedure. We've eliminated that. And for the 1 out of 10, you've given them a chance to really find out where their brain wants the eye to be. And you can put that muscle just where you want it to be. So we're really able to salvage their surgery and get great success overall.
Now, I understand the field continues to evolve. Dr. Mojan from Switzerland introduced an entirely new technique yesterday. Tell us about that.
Yeah, Daniel Mojan has been working on minimally invasive surgery. He has a lot of experience in all sorts of ophthalmic surgery, and he applied that to the concept of strabismus surgery. Smaller incisions in cataract surgery have transformed cataract surgery. So he wanted to do the same thing for strabismus, thinking, let's limit the amount of trauma and damage to the eye. And so he makes very small incisions and works through these small openings and is able to get to the muscle, sew it, tie it, move it, and barely really disturb the conjunctiva. In the end, he ends up at about the same place as you would end up anyway with traditional surgery, but he gets there much faster. In some ways, it's not unlike extracapsular surgery compared to phacoemulsification. The patients may have gotten to 20/20 either way, but the trauma to the eye is much less the way Daniel Mojan is doing it, and it's a very exciting advance. There will be a learning curve. Like phacoemulsification, surgeons will have to learn this new style, and I think there will be a reluctance because people think what they do today is already good, and they're hesitant to get better. It's always harder to go from 95% success to 100% success because those people getting the 95 are reluctant to change. But Daniel Mojan is really doing great work in educating people. He's a generous teacher, and he lets people come to his office in Switzerland to learn the surgery.
He uses an operating microscope for that, doesn't he? Will people be able to make that transition?
Well, in the U.S., most doctors use loupes to do the strabismus surgery. But around the world, many doctors use the microscope because if you go into an operating room, they often have the microscope available versus buying loupes as a separate purchase. So the microscope is available, and what we found out at the World Society of Pediatric Ophthalmology and Strabismus meetings, when surveying some of the physicians that came, many of the doctors, in fact, most of the doctors outside the U.S. were already using a microscope. So I don't think it'll be as big a transition outside the United States as it will be inside the United States.
Does this offer an advantage to patients in terms of comfort?
It does, and Daniel demonstrated patients who were able to get back to their life and perform within a day or two, which is really stunning because most of the time with strabismus, there's some redness and swelling, even if it's relatively atraumatic, which many of us can do, but the patient still has more discomfort than what he was demonstrating, so it's a quicker return. The other important thing about this is, in strabismus, the eyes don't always stay straight. So many years later, it's not unusual to have to do another surgery. And if you have to do the other surgery, the least trauma that was done originally means less scarring. So the next operation is likely to be more successful as well.
David, thank you so much for joining us.
Thank you for having me.
And thank you for joining us. For more information on this and related topics, please visit eurotimes.org.